Hi, my name is Amber Welsh. I'm a psych mental health nurse practitioner student at Eastern Kentucky University. This presentation is about the healthcare problem of postpartum depression. What is postpartum depression? It's a perinatal mood disorder with an onset in the first 12 months after giving birth. Symptoms include feeling sad, hopeless, empty, or overwhelmed, crying more often than usual, worrying or feeling overly anxious, moody, irritable, or restless, oversleeping, having trouble concentrating, remembering details and making decisions, anger or rage, losing interest in activities that were previously enjoyable, suffering from physical aches and pains, eating too much or too little, withdrawing from family and friends, having trouble bonding with her infant, persistently doubting her ability to care for her baby, and thinking about harming herself or her baby. What causes postpartum depression? It can be a combination of factors. There's a rapid decrease in progesterone and estrogen after delivery, a history of depression or anxiety in the woman's life, fatigue, life stress, such as moving or loss of a loved one, and emotional factors can all be a combination in causing postpartum depression. So why is it important to examine postpartum depression as a problem? In the US, postpartum depression occurs in 5 to 25% of childbearing women. The higher percentages in ethnic minorities and low socioeconomic status. Depressive episodes can devastate mothers and families, causing impaired mother-infant bonding in the early months of a newborn's life and may have lingering effects on intellectual and psychological development of the child. And it has been linked with an elevated risk of infant mortality, negative outcomes in some measures of infant development, and increased healthcare resource utilization. 2 studies were reviewed in this summary. First was by Milgram et al., the treatment of postnatal depression with cognitive behavioral therapy, sertraline, and combination therapy, a randomized controlled trial. The purpose was to compare the efficacy of cognitive behavioral therapy with SSRI monotherapy and combination of the two. This parallel 3-group randomized controlled trial recruited women with an Edinburgh postnatal depression scale of greater than or equal to 13. Depression symptoms were measured weekly for 12 weeks using the Beck Depression Inventory 2 and at 24 weeks using the BDI-2 as well. The first intervention group received CBT weekly in a group setting for 12 weeks. The second group received sertraline dosing by a psychiatrist, and then the intervention group 3 received a combination of the two. The results showed that the CBT monotherapy group with improved depression scores were higher than the SSRI monotherapy or combination group. And at 24-week follow-up, a higher percentage of women in the CBT-only group achieved remission from depression symptoms. The second study is by Nagai et al. Called The Effect of Telephone-Based Cognitive Behavioral Therapy on Postnatal Depression, a randomized controlled trial. The purpose was to evaluate the efficacy of telephone-based CBT for postnatal depression, both at 6 weeks and 6 months. It was a randomized controlled trial of 397 women with an EPDS score of greater than or equal to 10. That is adjusted for the Chinese version. Depression symptoms were measured at 6 weeks, and so 6 months postpartum, also using the EPDS. The intervention group 1 received weekly telephone-based CBT for 5 weeks, administered by a midwife trained in CBT, and the control group received standard postpartum care. The results showed that telephone-based CBT was associated with significantly greater reduction in depressive symptoms than standard care during the postpartum period. So how does the literature help to propose change to nursing practice? Awareness of the prevalence of postpartum depression is important, the knowledge of the risk factors, the administration of screening tool consistently in the prenatal period, after delivery, before discharge from the hospital or birth center, postpartum follow-up visits, and well child checks are all good times to administer a screening tool, and appropriate referral to mental health care. All of these were evident in the literature. A possible intervention for This is CBT in a postpartum program where nurses facilitate a CBT group on a monthly basis. It occurs monthly in a group setting with an option for more frequent individual sessions if needed. And these would be identified postpartum depressed women, either through a screening tool or a self-report. The healthcare environment that I have identified is North Country Healthcare. It is an outpatient community clinic in Flagstaff, Arizona. It provides perinatal, pediatric, and mental health services, and a postpartum depression support group already meets monthly with a licensed therapist as a facilitator. And so the intervention would take place either alongside the support group or in addition to the support group on a monthly basis with a psych mental health nurse practitioner providing the CBT. Thank you very much for listening to the presentation. We'll see you in summer in 892.